Bueno, pues tenemos un momento de preguntas.
Doctor, if you in the front line setting, you have a patient with NTRK fusion or in microsatellite instability, you give the treatment, the best treatment in the front line, or give chemotherapy and later the treatment?
Yeah, so I think a good question. I think the standard of care remains chemotherapy in this disease, and in truth we don't know this information typically for frontline treatment decision making, at least in the metastatic space. So typically it's second line or later. It's an interesting question though. If you did know and you have an older person or maybe a person who's less functional, there's some attraction to giving a low toxicity targeted approach. And the question of what to do for the MSI high patient is, I think, also unknown yet. We have seen some very nice responses in the anecdotally, for sure, because small patient numbers, but in the neoadjuvant setting for a couple of patients, and certainly in the later line of treatment as well. And if you did in fact know that, for example, a germline Lynch patient who has pancreas cancer, it is a tempting question of whether to integrate it as frontline. The approval is not in that setting, but I think we would get a pass in pancreas cancer if one wanted to consider this. And I'd be interested to hear what my colleagues think.
Yeah, so I think I'm more black and white. For NTRK fusions, I agree. I mean, that's a patient that needs to fail chemotherapy first. You know, with NTRK fusions, you do see interesting responses. They tend to be relatively durable, but not as impressive as immune therapy and MSI high. From my standpoint, if a patient has MSI high, I skip the chemotherapy and go straight for the immune agent. And the reason for this is simple in my mind. For at least 20 to 30% of the patients with MSI high plus cancer X, pancreas or others, especially with Lynch syndrome, there's a chance that this patient will go into durable remission that is the equivalent of a cure. You can never achieve that with chemotherapy. So with that approach, you could technically spare patients the need to ever receive chemotherapy. And so I start with an immune agent first. The reality is if they progress fast, they will progress fast on the immune agent, and you can always resort to chemotherapy.
¿Alguien más en el auditorio tiene alguna pregunta?
Thank you. For chemotherapy in the first line, FOLFIRINOX for the fit patients. For the unfit patients, maybe gemcitabine plus nab-paclitaxel. And for the patients with BRCA mutation, use of the POLO scheme.
Yes, I would say I think we have choices, right, for patients with frontline untreated metastatic pancreas cancer, and I think it's a discussion with the patient in terms of where the data are, what toxicities sit more or less comfortably for FOLFIRINOX support and an infusion, for gemcitabine and nab-paclitaxel in the absence of a cold cap, alopecia, and these are sometimes very strong determining factors for a given patient. But yes, I would say outside of a trial, FOLFIRINOX is the reference. Many of studies traditionally have built on the gemcitabine nab-paclitaxel backbone. I think it's good to see that that's now changing. We have a couple of studies, and one of them was the CPI 613 that is sort of building on FOLFIRINOX, and hopefully that's going to expand, and I think it is. And yes, for the patient who has a germline BRCA mutation, I think your options, platinum for sure as part of the initial treatment, either FOLFIRINOX, cisgem, or maybe FOLFOX for a less fit person, but in that setting I personally would go with cisgem, and the option for a PARP inhibitor as a maintenance approach.
So I mean, I do agree with attempting to use FOLFIRINOX in the first line, but that comes with caveats too. I think, one has to remember that they've never really been compared head to head, and there's certainly the bias, like you said, I see the good patient, I'm going to put them on FOLFIRINOX. I see the so-so patient, and I put them on gemcitabine nab-paclitaxel. We know biology is very important in this disease. The so-so patient is not going to do good. And so we've already established that this patient is not going to do as well. So when you treat 100 patients in your clinic, in your mind, your bias has already told you that, I've had a lot of great responses with FOLFIRINOX. I haven't seen so many with gemcitabine, Abraxane, nab-paclitaxel. And so it's difficult to say, which one is best. Frankly, at this point of time, so two things I think, and I agree, the every other week regimens are always better than the weekly regimens. The weekly regimens are rough and tough. One of the things of gemcitabine nab-paclitaxel that has made it difficult to combine with, although it's two agents, is the fact that it's weekly, and you oftentimes end up with more toxicities than desired. For the patient with a BRCA, I actually always like gemcitabine cisplatin instead of FOLFIRINOX. You see and obviously, from your study, the data looks incredibly impressive. You can't even say that the polo FOLFIRINOX data looks better than this. Historically, they look about the same. These are exquisite patients that are exquisitely sensitive to cisplatin. I would argue even better than oxaliplatin in that sense. And the good thing about gemcitabine cisplatin is there's quite a bit of data coming from a lot of groups, including ours, that suggest you can give it every other week, and you can give it for much more prolonged time than FOLFIRINOX. And in fact, you can even maintain patients on low-dose cisplatin without even ever the need to go to a PARP inhibitor at that point. So I actually favor for a lot of my patients gemcitabine cisplatin and continue to do so.
Just one question. So real world, Mexico, despite recommendation, patients do not have access to somatic germline testing. So would that be like a reason to select one chemotherapy regimen over other? Like, for example, not FOLFIRINOX, but FOLFOX, thinking about duplets, that not everybody can tolerate a triplet. But given the fact that probably 10% may have a good response to platinums, will that change your recommendation?
Yeah, so I think you bring up a very important practical point, David, right? And there's a whole real world out there that we have to certainly respect and understand in terms of practice patterns. Yes, so if there's a suggestion based on age in terms of family history or personal history that makes one think that there is the potential for an underlying mutation, that would sway me strongly in favor of FOLFIRINOX. I wouldn't give that patient cisplatin gemcitabine because we do have randomized data from older trials in unselected patients that that's not a win. But so FOLFIRINOX is the safe bet with that. FOLFOX has never been compared head-to-head, but we know from indirect phase 2s it's not FOLFIRINOX. So I'd be a little troubled by that and would perhaps, rather than pushing the dose with FOLFIRINOX, try to reduce it and see if one can make that tolerable. And for some patients we know we can, we know for some that we can't. It's certainly not a wrong decision to give gemcitabine and nab-paclitaxel to patients who have underlying germline mutations. In fact, we've seen some very nice responses in that setting too. I just think the totality of the data speaks in favor of platinum for those patients.
Aquí tenemos otra pregunta.
In terms of one over the other, I mean germline genetic testing or the somatic testing. If we don't have both, do you recommend one over the other, or is better to do both?
I think that's a very good question. So I think the bigger win right now, I would have to say, is from germline testing, and that's easier to do and doable for all. And thankfully, costs are coming down. You know, it's not universal yet in terms of this cost, but these panels for the 14, 15 core genes, are about $300 to $400. So that does make it accessible. I mean, I recognize that's not totally translatable. Ideally, both. Because I think that gives you the maximum amount of information. But if you have to pick one, germline is where I'd put the money.
Totally agree, except I think you really need to do both. These days, it wouldn't even make sense anymore not to have at least the BRCA somatic, because we know that there is about another 2 to 3% that have a BRCA somatic mutation. And we know, at least historically from data here and there, that somatic mutations can predict equally for a great response from platinums and PARP inhibitors. And so you will miss on half of the patients cumulatively who would have some level of BRCA or BRCA-NS. But also you will get your NTRK, you will get your MSI, although at a very low rate, but you still get those patients. And then now that we're learning more and more about the KRAS wild types and the presence of these fusions, BRAF mutations and others that could be targeted primarily on clinical trials at this point of time, I think it becomes very important to have the data. To get KRAS alone is actually today not any less expensive than getting the whole panel. So if you want to get it, just get the whole panel, if you can.
¿Tenemos alguna otra pregunta del público?
I have a question regarding the response that you see in patients that have these BRCA mutations to cisplatin therapy. So you can actually see very profound responses for long periods of times. So we actually treated a case in which we could document a complete clinical response and actually a complete pathological response. And that was the reason why is that we sent the patient to the OR despite having a pancreatic cancer and some peritoneal implants. Do you foresee that this is going to be a conduct that will start, doing more often?
Ladies first.
Thank you. Yeah, so I think it's an interesting question, but I think people who are, on the tail of all of the curves of all the trials that have been done over, the last 20 years, they're probably enriched for these patients. We just didn't know it for all the time to come. And I do think that for some, we're going to be breaking the rules, right? And this is maybe where selected surgery or ablation or other local therapies may have a role. And some indeed do have these profound and durable responses, but I would also say we do see a subset too who have the same kind of rapid, aggressive biology that don't respond to these drugs. That's present as well, but enriched for the better outcome.
So I think I'll take this question from a broader perspective, not necessarily just the BRCA, but overall we have been, at least at Mayo and I know other places as well, integrating more and more the aspect of bringing local regional approaches into pancreas, especially for those patients who appear to have a biology that's very different, that's slow. Patients are doing great. You see that one lesion in the liver that hangs in. So we have numerous examples. I mean, some of them are being done locally in clinical trials, but I have an example of a patient who is now 8 years out. So that was when I was at Ohio State before I moved to Mayo, who essentially was a physician presented with to another institution, not to be named then, had a Whipple, and then they figured out there was a lesion in the liver. Closed him down, biopsied the liver tumor, and then he came our way, and he was insistent that he essentially wanted to have that liver lesion removed. So we said, you know what, we're going to give you a little test of biology. Back then I put him on gemcitabine cisplatin. Now this patient turns out he has none of the mutations, alterations that we think that was done later on. So we ultimately, after 2-3 months of GemCis, the patient was doing fantastic. We removed, he actually underwent liver resection, and then gave him another 3 months of GemCis, and he's 8 years out in complete remission. So there are these examples, and it's not an N01. There is another example of exactly like your patient, FOLFIRINOX and a BRCA alteration with a liver and and a pancreas, same thing, 5 years out. Again, so you see those patients now. Unfortunately, this is only a small % of our patients. But I think we need to open our minds, as we do with other cancers, and consider local regional approaches, even in the metastatic setting.
¿Alguien más del público? Bueno, a mí me gustaría hacer una pregunta. Actualmente existe el papel del mantenimiento, estamos viendo en el uso de platino. ¿Existirá el término platino sensible, platino resistente en este grupo de pacientes?
I might need some help. Yeah. So thank you. So the question is, what are the definitions for platinum-sensitive and platinum-resistant disease in pancreas cancer? So very good question. We do not have any accepted definitions. We extrapolate a bit from ovary cancer, and thinking being if patient has progressed on or within 6 months, probably is speaking to platinum resistance, and that's relatively poor surrogacy for benefiting from both further platinum but also potentially a PARP inhibitor. And that's one point that hasn't come up in our discussion that I think is worth bringing up, is the data supporting the use of PARP inhibitors when people's disease has grown on platinum therapy is very weak. And it's not zero, but it's a high surrogacy for seeing resistance and not benefiting from that. And that's, in my opinion, a big argument to think about integrating PARP inhibitors sooner rather than later, and not waiting until the disease has changed, because then I think we're losing our opportunity to add what they may bring to the table.
Yes, totally agree. And to add, if one can add anything to that, it's just single-agent PARP inhibitor activity in pancreas cancer is not optimal. It's actually, compared to ovarian and breast, it's a small %. It's less than 20%, whereby in ovarian you see 50%. And a lot of them tend to be less durable. And so to that point, it makes a lot of sense to bring those PARP inhibitors to earlier on. Whether in reasonable combinations, there's a challenge with combining these PARP inhibitors with chemotherapy, but there are ways to do that. We're looking at some, but with immune therapies, with MEK inhibitors, there's emerging data about other mechanisms of resistance to these PARP inhibitors in pancreas cancer through the upregulation or activation of the MAPK pathway. So there are ways to enhance the activity of these PARP inhibitors in pancreas cancer that are rational, which we hope will enhance the activity of these agents singly and doubly.
Bueno, si no hay ninguna otra pregunta, muchas gracias. Gracias.